Welcome to another episode of Age Better. Today we're diving into a critical and increasingly prevalent health issue that can affect millions of people, including postmenopausal women, women in midlife. Atrial fibrillation, sometimes known as A-Fib. We'll explore why AFib might be more common in women than previously thought, the risks associated with undiagnosed AFib, which happens a little too often, as you'll soon hear, and the latest advancements in treatment options. And there are quite a few. Joining me to shed light on all of this and more is Dr. Nisha Parikh, System Director of the Women's Heart Program and Director of Cardiovascular Medicine at the Katz Institute for Women's Health, and co-director of the Center for Women's Heart Health at the Northwell Cardiovascular Institute. Dr. Parikh, thank you so much for joining us. Welcome to Age Better.
Oh, thank you so much for having me on the show. It's really an honor to be here.
So let's start at the top. Can you please explain to us what is atrial fibrillation?
Sure. So atrial fibrillation is a condition that we see as folks age, although sometimes it can happen earlier on in life. And it's an electrical disorder of the heart where the electricity no longer really comes from the normal pacemaker of the heart called the sinus node, but rather it comes from various spots in usually the left atrium, which is the left upper chamber of the heart. And when that happens, the impulses don't come at like a regular cadence. Like a regular cadence would be like a marching band, but they can sort of come whenever. You can't sort of time when the next heartbeat's going to come. And with atrial fibrillation, those heartbeats aren't subject to the normal feedback that our heart usually has when it's when the conduction comes from the pacemaker. So our heart rate might not slow down when it's supposed to, and it might go too fast. That's really one of the issues that can happen with atrial fibrillation.
Mm-hmm. Now, with projections saying 12.1 million people could have AFib by 2030, so it's on the uptick clearly, and nearly a quarter of cases going undiagnosed. They just don't know they have it, and many of them are postmenopausal women. Why might AFib often go unnoticed, and especially in women? Why?
Yeah, that is such an important question. I think it's because women seem to be more likely, although they are more likely to seek care for their symptoms than men when they present with AFib. There's also some data that suggests that women tend to have their symptoms for much longer than men by the time they do show up to get care. One reason that AFib might not be recognized in women is because they do tend to have symptoms that are relatively nonspecific. So they might describe weakness or fatigue, and they might not say, there's something wrong with my heart and the way it's beating. And that's a sort of more direct symptom of AFib. And so it might not be recognized for that reason, really because women tend to present with symptoms that were previously known as atypical, but we don't like to use that terminology anymore because, of course, women are half the population, and whatever symptoms they're having are typical for them. So they're just as important and real as symptoms that we sort of like call typical.
Right. And also it's a very confusing time for women in midlife as they're going through menopause. And with menopause, very often, as you know, women can experience heart palpitations that might not be AFib at all. Just kind of temporary reaction to, the drops in estrogen and the different levels of estrogen that are going on in your body until it completely drops when you become postmenopausal. So that could be happening too. And then maybe many women who are very aware of the symptoms of menopause, as more and more women, thank goodness, are becoming aware of menopause and more knowledgeable about menopause. They might be thinking, oh, it's just menopause, right? So that could be happening too, I could imagine. So,
definitely.
Right?
It's getting kind of it's sort of muddied by all the other things. And then meanwhile, they might be getting some sort of, quote unquote, reassurance from maybe from a general doctor or anybody their friend or their mother, oh yeah, that just happens. Don't worry about it. It's going to pass. Like once you
Right.
get, get through it. So absolutely, I think there's that minimization of things that go on around the time of menopause. Yeah,
Exactly.
which we shouldn't be doing.
No, not at all. Not at all. It's a confusing time. So, considering the significant impact of psychological and social stressors
Hmm.
on postmenopausal women's risk for developing AFib, as I saw
Hmm.
in quite a few studies, according
Hmm.
to some new research, could you talk about how those factors like sleep
Hmm.
deprivation, sleep, such an important thing that
Yes.
really has been played down for too many years, thank goodness is now being played up as it should be. How can that play into this, and what can we do to mitigate the effects?
Yeah, that is such a good question. Sleep, in particular, as you mentioned, can be unfortunately disrupted during menopause. That can range um, from insomnia, so kind of the more extreme form of a sleep deprivation, to just sort of sleep disruptions that make the quality of sleep less effective. And then as some women go through menopause, they might even experience some weight gain and they might develop sleep apnea as a result, which is sort of, I think people are hearing about it more and more, but it's periods of time during your sleep when, unbeknownst to you, you're sort of stopping your breathing. And that over time can lead to AFib, sleep apnea itself. Insomnia, if one is, if you have that sort of more extreme form of sleep deprivation, that can raise the risk of AFib by 30%. So, these are really significant risk factors that I think postmenopausal and perimenopausal women it can experience that put them at risk for AFib. And then your second part of your question was, can treating help? I absolutely. If you have a diagnosis of sleep apnea, getting treatment for that can be helpful. Some of that could look like weight loss for some people, but for other people, it might require a mask, wearing sort of a breathing mask during sleeping, CPAP, and that can sometimes help the issue of AFib. And then
Right.
finally, if you have insomnia, getting some treatment for that can be helpful.
And so it also sounds as though if someone has sleep apnea and has been diagnosed with that, um, they should be even more aware of the differences in their heart rhythm. I would think, like more
Absolutely.
tuned into
Yes.
it.
Yes, definitely. And
Hmm.
AFib is one of those rhythms that we're worried about if somebody has sleep apnea.
Hmm. So now recent studies show that and I found this to be fascinating, when adjusted for height, women are more likely to develop AFib than men.
Hmm.
Now, what do you think causes that difference, and how does it affect how we
Yeah.
diagnose and treat AFib?
It is a little bit of an area. I read that study too. It's really fascinating because um, the issue of body mass index, we sort of as a knee jerk have been adjusting for body mass index for in all of our studies, because we never want that to be the reason that we see an association between like X and Y or A and B. And in this case, that might have been inappropriate. And it might be that there is a unique association with height and AFib. But I have to say that I don't know what underlies it. I don't know if it's something genetic that sort of connects height and AFib that we don't know about, because some genes travel together, and it's not that like height is causing AFib, but it's just they happen to travel together in our DNA, and so that might be the case. We do know that, for instance, people of white European ancestry are more predisposed to AFib than individuals of African American ancestry, or even some Asian ancestry. So that's likely there's a genetic underpinning, and maybe height somehow plays into that too.
I
So I
was
think,
going to ask you
yeah.
about the genetic component. Does it run in families? If your mother or father had AFib, are you more likely to get AFib, or how
Yes.
does that work? The answer is
It
yes.
does. It does, for sure. It's not the only thing. It's not sort of like a slam dunk that you'll get it if your parent had it, but it definitely raises your risk if a parent had it. It
Hmm.
does tend to run in families. We are seeing it more and more as folks live longer and longer. And then we're also seeing it more and more. One reason is because some of the risk factors for atrial fibrillation are the same things that are just sort of happening in Western society that put people at risk for heart disease. So having a little extra weight on board, high blood pressure, diabetes, these can all increase a person's risk of atrial fibrillation as well.
Got it.
Mhm.
What are the typical signs that someone might have AFib? And do these symptoms appear differently in women than they do in men?
They definitely do appear a bit differently. Women tend to describe, again, sort of like weakness or fatigue. Men are probably a little more likely to describe sort of like palpitations, maybe even lightheadedness. Any of those could be a cause of AFib, but sometimes a patient will come in my office and just say outright, there's something going on with my heartbeat. It's beating kind of funny. I'm having palpitations. And then, believe it or not, Barbara, it turns out that just a doctor feeling your pulse rate is a really good way to diagnose AFib. Even over and beyond sometimes like, getting sort of random EKG testing and that type of thing. So
Right.
just doing that history, listening to the heart, and literally just, feeling the pulse like this can be effective because you can feel when something is beating regularly. I think we have like a really good sort of like in tune sense. I'm not really much of a music person, but even I can feel a pulse rate that's not happening at a beat.
Exactly right.
Yeah.
Yeah,
Yeah.
feeling the beat.
Hmm.
Can you explain the major risks of leaving AFib untreated? Like, what if
Yes,
you have it?
absolutely.
I mean, for many years you don't know you have it, or you even know you have it, but you decide, oh, okay, I can handle this on my own. What are the risks?
Sure, that's a great question. So I want to just start by saying AFib in and of itself is not usually a dangerous, life-threatening condition. So if you have it, it's not that it's incompatible with sort of perfusing your organs or, sort of getting blood to the places that your heart needs to get blood to. But aside from symptoms, which is really one big problem, if you're feeling it and feeling uncomfortable, the things that we worry about are if your heart rate's going too fast, if it's going too fast for several weeks at a time, and that those fast heart rates are accounting for at least 15 to 20% of your heartbeats, then the heart muscle can weaken over time and you
Mhm.
can develop heart failure, a weakening of the heart muscle caused by atrial fibrillation. The other type of heart failure that can happen from a leaky heart valve from AFib. And that can happen because those top chambers stretch and that the area where the valve sits, which is a door between the top and bottom chamber, that stretches, and that can cause leaking of blood backwards when it's supposed to be going forwards. That can cause a form of heart failure as well. And then the other big thing we worry about is a stroke. And the way that works is with that irregular heart beating of that chamber, the left upper chamber where the atrial fibrillation comes from, if your heart is beating that way for long periods of time, that can lead to the blood flow slowing down in that chamber. And that slowing of blood flow predisposes to developing a blood clot. And unfortunately, with AFib, that is one of the biggest risks we worry about is the risk of having a stroke,
Mhm.
because that risk in many people is increased over and beyond if you didn't have AFib. So in those individuals, we like to recommend a blood thinner.
A blood thinner. And why are women, at least this is what I've seen in all the
Hmm.
research I've looked at,
Mhm.
why are women with AFib at a higher risk for stroke?
That
And
is a
how does that influence how you treat women?
Yeah, I mean, that is such a good question. I don't know if we have a definite answer to that question, but there's been a lot of mechanisms that people have studied and that we hypothesize might underlie that issue. One is just alterations in the way that blood flows through a woman's heart and through her blood vessels. And there's been some thought that maybe the sort of trajectory of blood flow might predispose to blood clotting. Hormones might be another reason. Estrogen itself can cause blood to be a little bit more thick, in the sense that it might be predisposed to clotting. So that has also been proposed. And then maybe hormone replacement therapy in the past has been proposed as well as a potential reason that a woman might be predisposed to blood clotting. And then finally, inflammation. So, are women sort of more predisposed to inflammation, especially postmenopausal women? And could that be the reason? But I have to say that we don't know entirely. And I think this is a really important area of research.
Oh, it really is, and as we've seen, there's been an uptick in funding for
Hmm.
women's health research, which is really great news. Not starting with, but recently, the White House did announce this quite a bit of money put behind women's health research. And I certainly hope that this is, focusing on this specifically is going to be a part of that.
I hope so too.
Yeah, really. So, but one thing I want to just be clear on. So, we just did talk about women's risk for stroke. Now, is this women who are being treated, they still have a higher risk for stroke, or women who have AFib but don't know it, they're undiagnosed, or both?
It's mostly the second category. So it's mostly women who are at a risk, an increased risk for having a stroke, and they don't know it. And we usually base our recommendation about blood thinners on if a woman has a certain set of extra factors that put her at additional risk. So we wouldn't just sort of with just kind of like a wide blanket treat everybody with a blood thinner who has AFib.
Right.
So those risk factors that would put someone at extra risk for developing a stroke with AFib would be age. So usually we'd say sort of like an older age,
Mm-hmm.
the presence of high blood pressure, if you
Mm-hmm.
have diabetes,
Mm-hmm.
and those types of things. If you've had a prior stroke, definitely, that would put you at extra risk as well.
Right, right. Definitely getting older
Mhm.
for sure, I know is a
Yeah.
risk factor. And what are the current best practices for treating AFib, particularly for women? I mean, if they are treated differently
Mhm.
than men. And do these treatments vary? I guess the answer is yes, based on individual risk factors. As you were just pointing out, it depends upon your other risk factors as
Yeah.
well, right? But what is the current thinking about treatment?
Yeah, usually the things that we tackle first, if someone's in AFib, we try to decide, okay, are we going to treat their heart rate and use sort of a heart rate control strategy, or are we going to try to get them out of atrial fibrillation and use a rhythm control strategy? Or are we going to try some sort of combination where I might say, okay, I'm not going to be able to get you out of AFib today. How do I get you out of AFib? Well, usually it would involve what we call a cardioversion. So where it's kind of those dramatic scenes where you're shocking somebody out of a rhythm. But in this case, again, it's not a life-threatening thing. We just want to make you feel better for the most part.
Hmm.
And so we would sort of get you out of the atrial fibrillation with delivering some electricity to your chest wall. And then that usually would do the trick to get you into a normal rhythm, at least for some time. So it might be that we'd want to do that down the line and first try to just slow the heart rate down, see if maybe your body will get you out of atrial fibrillation right away. With thinking about kind of getting somebody out of AFib, we always have to at least temporarily put them on a blood thinner, because it's really that time when you're in AFib and converting to a normal rhythm. We believe that that's the time when the blood is most susceptible to clotting and developing a
Interesting.
stroke.
I was just
Yeah.
going to ask you that. Like, at what point in the whole kind of process of
Hmm.
being in AFib, then getting out of AFib, are you at most risk, at the greatest risk for
Yes, and
stroke?
that's exactly the time period.
Interesting.
It's that period, that 48 hours really, ish, I don't want to give
Yes.
that exact number, but around that period of time when the heart converts from atrial fibrillation into a normal rhythm, it's sort of stunned. It's sort of just sitting there, not contracting the way it should. And that's true whether you sort of spontaneously, your body gets you out of AFib, or if we do it with the electricity or a drug even to
So
get you out of AFib.
that's like the danger zone really for
Hmm.
those. But if you're already on a blood thinner,
Hmm.
then are you still in a danger zone?
Probably
It
not.
okay.
But now we're a lot more cautious. I think the stakes of having a stroke are, we always feel very serious. We take that very seriously, I should say, as physicians, because you know what, the downside of not knowing whether, like Barbara, maybe say you or I have AFib and we've been on a blood thinner and we're pretty sure we took it every day, but maybe there was that one day we didn't take it. We can't remember. So we tend to be a bit more cautious, and if there's any question at all, we would sort of check if there's a clot in the heart to the best of our knowledge, and we do that with an echo, an ultrasound that's done through the food pipe or the esophagus. And so it's a tube about the diameter of my finger, and we would have someone swallow it down under with some anesthesia, so that they feel comfortable. And then we'd take a look behind the heart, and we can see, sort of we can get a really nice view of the heart usually and see if there's any blood clot we'd be worried about. Yeah.
Got it. Wow, so
Mhm.
fascinating. Do most people pop out of AFib on their own, or do most people need a cardioversion or some other technique to help them to get out, or is that even known?
No, I think it depends how long the AFib has been present. So the
Hmm.
longer you're in it, I guess the more your heart gets used to it and the harder it is to get you out of it.
That makes
Um,
sense.
yeah. And so we usually like to try to get somebody out of AFib at the beginning. And a lot of our clinical trials are showing us that that's probably the right strategy. For many years, we felt that a rate control strategy and a rhythm control strategy were equal in terms of outcomes. But I think the more recent data, the more recent clinical trials have been showing us that getting somebody out of AFib probably is better for them in the long run, in many ways to prevent heart failure and other issues. And then just to finish, Barbara, you were asking like the other treatment considerations. So the other treatment considerations are really the stroke prevention. And I think we covered that, but it's deciding whether, with them in kind of a shared decision-making fashion, whether they'd want to be on a blood thinner to prevent stroke, and kind of what our recommendation is for that. So it's sort of the rate control, the rhythm control, and then the stroke prevention. Those are the main treatment
And then where does
considerations.
cardiac ablation fit into
Yeah.
this?
Yeah, that's such a good question, and a more increasingly more common treatment that's gotten better and better over the last several decades. But essentially, what that is we take a catheter and put it up to the heart. It comes in essentially um, through the veins. So a vein in the groin, we'd sort of enter through there. So it's not an open heart procedure usually. And that catheter would essentially deliver energy to where we think the circuits are, that where the AFib originates, and we would electrically isolate those areas, and sort of zap those areas. And in many cases, it can help reduce the burden of AFib. It can help somebody's symptoms, and sometimes it can stop AFib. It generally doesn't cure it completely, and so it's always sort of an issue of, okay, probably need to remain on a blood thinner, probably need to monitor you for AFib in the future in case it shows up again. So that
Mm-hmm.
those types of things are often necessary even after an ablation. But an ablation can be very effective for the things I mentioned, for sort of alleviating symptoms, burden of atrial fibrillation, and we believe it might even prevent heart failure as well from occurring later on.
Oh, that sounds like it really
Yeah.
does a very good job at helping the
Yes.
situation.
All
But
important
you
things.
all important things, but
Yeah.
you did mention it probably doesn't cure it because from what I've read, there really is no cure for AFib, right? It's just something that you work with your trusted healthcare provider in
Yes.
managing.
Yes, it is certainly a chronic condition. I would say in rare cases we could sort of take care of it with that type of surgery, but it's probably less often than not that that would be the case. Yeah.
Right, right.
Yeah.
So, metformin, let's talk about that for a minute.
Mm.
I have a fascination with metformin. Metformin
Okay.
is, as you know, it's an old medication. It's inexpensive. It's been used
Hmm.
for diabetes, but I do follow a lot of longevity experts, and
Hmm.
for quite a few years now, they've been studying metformin
Hmm.
as it relates to longevity. And so,
Hmm.
they're looking for other uses for this inexpensive, easy to take medication. And I read recently some research that they are now looking at metformin for AFib.
Hmm.
What are you thinking about that? What are your thoughts?
My initial thoughts are I think it's a good idea to study a drug that we have decades of data on, we have safety data on, we know is effective at both preventing diabetes and treating diabetes. So, another sort of important cardiometabolic disease. So, my initial impression is that I think it's a great idea to see if this is effective in treating atrial fibrillation. And in some ways, many patients, we could kill two birds with one stone by using such an approach. So, I would
Right.
certainly be in favor of large clinical trials that might show that this could be effective. I think pursuing that is a very good and strong idea. So,
Yeah. I'm all in favor of trying new things, especially things that we know already do help to fix, if you will, use layman
yes,
terms, some
absolutely.
of the
Yeah.
related, risk factors like
Yes.
diabetes, right? So,
Yes,
I mean,
absolutely.
so maybe if used in a different dose and the like, perhaps it could someday be FDA approved for that. So we will see.
Absolutely.
Another thing I've been really keeping a close eye on is magnesium, and
Hmm. Hmm.
magnesium less from what I've seen, less about
Hmm.
preventing AFib, but more about treating AFib once you've
Hmm.
had it. But what are your thoughts on magnesium?
Yeah, so I mean, I think that for AFib, there have been some publications that suggest that magnesium might have been able to sort of prevent AFib, but then when you put all those together and do what we call a meta-analysis, it didn't show that there was sort of like an overall benefit for preventing AFib. That being said, I think over-the-counter magnesium is a really useful medicine for women who are in perimenopause and even postmenopausal. It can help with sleep. So if I often suggest taking 500 milligrams at night to help with sleep, to help with sort of it's almost like a way to keep things regular in the GI system, if you will.
Yes.
And then I also think it can help with lowering sort of like mild anxiety and
Mm-hmm.
mild, sort of stress as well. So I think it's a really helpful medicine in general. That being said, I don't know if that dose would help prevent AFib. But then the other story with magnesium is that there have been a number of studies over several decades that have now been sort of like pooled together that of IV magnesium given sort of like more in an emergency room when we're trying to get somebody out of AFib or rate control them. And that does seem to have a signal of potential benefit. But I think the jury is still a little bit out there, and we might need a large clinical trial to really look at this rather than trying to put all these small, kind of heterogeneous studies together. So,
Right. But one thing, magnesium does have other benefits. So if you happen to have AFib, I guess, why not take some magnesium, right?
absolutely,
Because
yes,
it
definitely.
benefits you in other ways, right?
Yes, definitely. And I think no, you're absolutely right. And interestingly, magnesium for us as cardiologists, for heart doctors, we do like to see it in this like really sort of narrow sweet spot of so when you look at the normal range of magnesium, we're like a little more greedy and we want it to be even a little bit, just exactly at the middle of that normal range. So yeah, I think magnesium's a good thing.
It's a good thing.
Yeah.
I'm adding it to my shopping list. So prevention is key, I think, for so many things that can happen to us as we get older, and certainly for AFib. So prevention is really key when it comes to AFib, really when it comes to so many things that can happen to us as we get older, of course. But
Yes.
so what do you recommend to people to prevent developing AFib?
Yeah, there's a lot of data that suggests that sort of doing lifestyle change can be helpful for AFib. So, ha adopting heart healthy diet, what does that mean? Mediterranean diet is very helpful at sort of reducing overall cardiovascular disease, but it's also been shown in sort of sub-analyses of large studies of Mediterranean diets to prevent cardiovascular disease has been shown to also reduce the risk of atrial fibrillation. Lowering blood pressure is really important, and I would love to take this opportunity to just talk about a few ways to do that in general. And I think they'd also help prevent AFib, just vis-a-vis the lowering of blood pressure. One is salt reduction, so lowering salt intake to less than 2 grams a day or 2,000 milligrams. I am always surprised at how much sodium is snuck into food. And,
Yes, especially when you
certainly
eat out, when you're not
yes,
cooking it
especially
itself.
when you eat
Hmm.
out. We have no idea, but I'm just assuming it's a lot. But even sort of what I consider healthy, like maybe I want to, choose like to make something with like canned legumes. But just looking at sort of, oh wow, this can of black beans, like if I'm to eat, half a cup, wow, it's like, a large fraction of that 2,000 milligrams. Or, oh, I'm eating something from Whole Foods. It's frozen, but I think it's going to be healthy. Well, when I look at the sodium content, it could be like 900, 900 milligrams. Yikes, So I think that, and that's again about half of what you're sort of allotted for the day. There's just a really insane amount of sodium in processed food. So I usually tell my patients if they're thinking about blood pressure reduction or prevention to just log the sodium that they eat for a few days as a gut check. So anyhow, sodium lowering, adding fruits and vegetables to your diet, 5 to 7 servings a day. Try to add it to each meal. Extra servings of vegetables, maybe a fruit or two throughout the course of the day. That in and of itself can lower your blood pressure. And then another, I think, really nice technique is deep breathing. So time deep breathing. And one technique that I can just share is box breathing. So breathing in over 4 counts, holding it for 4 counts and exhaling for 4 and holding it at the end. If you do that, sort of a few times a day, 2 to 3 times a day, like maybe 5 times, 2 to 3 times a day, that type of time deep breathing has been shown in studies to lower somebody's blood pressure. So that's kind of a nice, easy technique.
I'm a big fan of box breathing
Oh,
and have
good.
been for a number
Okay.
of years. And
Oh, that's
especially
good.
I want to say about 2 years ago, I had a breathing expert on. He's written books about it.
Oh,
He's from
wow. He knows
Ireland,
more than I do for sure.
and it was incredible. I mean, we spent an hour talking about proper and improper breathing and all the ways that improper breathing can have an impact on your health, your mental
Ah,
health also,
wow.
but
That's
also your physical
wonderful.
health. It was incredible. And so box breathing has become something that I personally do at
Oh,
night
that's
if I'm
that's
trying to go
great.
to sleep, or just as a way, as like a form of micro meditation.
Yes, absolutely. It has so many benefits, I think. Yeah,
Hmm. And what
absolutely.
about alcohol? Where does
Oh,
that
yes,
fit
that's a
into
good.
AFib?
Yeah, so alcohol, sort of more than moderate alcohol intake and certainly binge drinking can affect our risk of developing atrial fibrillation. Sort of classically, many of us have noticed that we will see new onset of atrial fibrillation after somebody has had like a binge drink. And that was called holiday heart because
Holiday
somebody
heart. Yes,
might
I
be
read
at
about that.
Thanksgiving or Christmas and,
Hmm. New
sort of have a higher
Year's.
than usual intake. And then we'd see them in the emergency room because they weren't feeling so great with the atrial fibrillation. So alcohol can be a risk factor for atrial fibrillation. And for women in general, just for overall sort of like heart health, we wouldn't recommend having more than a glass of alcohol a day, so a glass of wine or beer. Um, sort of so no more than 7 drinks a week. And
Right.
those so-called benefits of alcohol were now more and more noticing in studies might not be there the way we thought before. We used to sort of be prescriptive about, oh yeah, have a glass of wine, you know.
Right.
And now I think we're kind of, as a medical field, shying away from that. It doesn't seem like the risks are worth any potential benefit, or maybe there wasn't a benefit to begin with. Yeah.
Right,
So,
right, right. So many
mhm.
studies coming out about that now.
Yeah. Yeah.
So I do want to talk about wearables because I find it
Oh,
fascinating.
absolutely. Yeah.
Just a week or two ago, the FDA approved the Apple Watch. I'm holding up my Apple
Yes.
Watch. I measure every
Yeah.
part of myself with this Apple Watch. They just
Yeah.
approved it for monitoring AFib. Which
Yeah.
is really incredible. FDA approved. So more and more people are wearing wearables, are wearing
Hmm.
devices, whether it's a ring
Hmm.
or a watch or what have you. And these are ways that you can actually measure you can do an EKG, you can measure your
Yes.
heart rate. If you're feeling like, oh, my heart feels weird, let me do an EKG,
Hmm.
which I
Hmm.
do almost every day because, you become obsessed. What do you think about that?
Yeah, I in general am a fan of wearables. I'm probably not a zealot thinking that everyone needs one so that they'll all know about AFib. I'll tell you why.
Oh, good. I
So
want to
so let
hear.
me start with the things that I definitely am a fan of. So I have not infrequently um, asked my patients with Apple Watches to like kind of record the AFib on their Apple Watch, if we're trying to get a sense of how many, like when they have episodes and how many they're having, and we've sort of done the heart monitor and the more sort of like standard testing. The Apple Watch can be really useful for that. Um, where I sort of pause a little bit is sort of the widespread kind of like use of the Apple Watch in the general young, otherwise healthy population, because the studies that have come out with regards to screening for atrial fibrillation haven't suggested that that approach prevents strokes or like improves patient outcomes. And that's really, again, for sort of like the whole umbrella of the population. So that would be, the college age student running around with the Apple Watch, knowing if they had AFib, it's sort of like it might be akin to sort of like those incidental findings like on a chest x-ray. Like, are those always helpful? Probably not. It's probably not always helpful to like screen everyone with a chest x-ray, because we're going to end up finding things that
Something.
don't something, but they're not going to, it's going to lead to more treatment, but maybe not a better outcome. And that's what the studies suggest so far with like universal wearable screening, even in older patients, believe it or not. And this kind
Really?
of comes back to that point that that palpation, and this is like when it's tested against like an office visit and palpation and that type of thing. So, but I think Apple Watches and the FDA approval, to me, it sounds useful because so many more people have an Apple Watch. And if we are trying to get a handle on someone's burden of AFib, if we know they have it, it seems like a reasonable thing to be able to use that as a screening device. It's a lot less cumbersome than some of the other monitors we have. And then for somebody who already owns it, it's probably less expensive, honestly, than us ordering like, a 2 week, a 1 month heart monitor.
Right, 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 right.
Yeah.
So you're not saying
Mhm.
everyone run out and get an Apple Watch. You're
No,
just
no. I mean, like I wouldn't say that no matter what, because it's expensive for everyone, like the
sure.
general population. But then the second reason is our data doesn't suggest that running out and getting one is actually going to prevent a stroke or like increase or improve your outcomes.
Got it. Got it.
Yeah.
So this was incredible. I feel like we covered everything. I'm racking my brain right now to see if I have any other questions. And I think that I will. And I would love to invite you to come back. I also always
Oh,
get
I would love
questions
that.
from the audience whenever we have these episodes and with people asking follow-up questions. And so I think I would like to collect those. So everyone listening in or
Sure.
watching on YouTube, send me your questions, leave them in the comments section. and we can have a follow-up conversation. There is something I do want to talk to you about, but we don't have to do it now. We can save it for our next conversation. It's about,
Okay.
the vagal tone, um,
Okay.
vagal nerve. I've read so much about that as it relates to so many things that are going on in the
Okay.
body, not just AFib. And I really would like to have a thorough conversation about the
That would be my
vagal nerve
pleasure.
and vagal tone and everything else that it does. So thank you so much. I know how incredibly busy you are, and I so appreciate everything that you are doing for women on behalf of women with the work that you and your colleagues do. Thank you so
Oh,
much
you're
for
very
that.
welcome. Thanks for having
Really,
me on, Barbara. It was a
before I
pleasure.
let you go,
Yes.
you're not going so fast. Before I let you go, do you have three or however many you'd like key takeaways? Because we covered so much, just a few
Hmm.
things you really want the Age Better audience to remember from this talk today.
Okay. So, for all the women out there, or for the men who are thinking about women, your loved one, take your symptoms seriously. So, if you have any symptom that where you're worried it could be atrial fibrillation or any other heart-related issue, please take that seriously and go and see a doctor. So, if it's something like fatigue, you know what? Many women, that is their presenting symptom. So I'm giving you permission to see somebody for anything that you are worried about. The second take-home point is that in many ways, AFib is preventable, and it's really about improving your overall lifestyle as it relates to the heart. And it's kind of doing the things that we're asking you to do to prevent a heart attack or a stroke. So many of the risk factors for atrial fibrillation are just the same as they are for those conditions. So eating a heart healthy diet and exercising can be really, really helpful to prevent AFib. Um, and then I guess the third point would be there are a lot of new wearable devices out there. And so, uh, I think that especially this audience might be wondering if you should run out and get the next new thing. If you don't have AFib, but you think you're at a high risk for it, it could be helpful. But I wouldn't want everyone to run out and go get an Apple Watch or any other sort of device that you see on the market. Have a discussion with your doctor about it first. That would be my advice.
Thank you so much for that incredibly wonderful advice. Thank you so much for joining me, and I know you'll be back.
Barbara, it was a pleasure. Thank you and have a great day.